Dear participants and organizers, good afternoon. I'm grateful for the opportunity to speak at this Global Wellness Equity Conference 2026. I'm Innocent Zaimana. I'm a consultant urologist. This conference comes at the right time where the need to talk about wellness is at its highest, especially in Rwanda. My talk is about wellness challenges and solutions throughout the surgical career. I will argue that these challenges do not appear only at one moment. They begin early, change over time, and intensify in settings where the surgical burden is high, but the workforce and support structures are limited. In contexts such as Rwanda, wellness is not separate from surgical system strengthening. It's one of its foundations. Globally, more than 5 billion people still lack access to safe, affordable surgical anesthesia care. In Rwanda, leaders recently reported that the country has about 162 surgeons, while it needs around 1,000 to meet the demand. You understand the big gap. At the same time, a survey of perioperative health workers in Rwanda found that about 1 in 5 reported burnout. These numbers matter because they show the double pressure facing surgical systems in many low and middle income countries. An intense unmet need for surgery and too few professionals carrying that load. Under these conditions, wellness becomes a workforce issue, a quality issue, and an equity issue. The nature of stress changes across surgical career. For students and interns, common pressures include performance anxiety, the emotional impact of seeing patients suffering, and the formation of professional identity. When you move to residency, it adds intense clinical service demands, sleep loss, and the tension between supervision and autonomy. Early consultants then face high responsibility, career insecurity, and the pressure to build confidence while making difficult decisions independently. By mid-career, administrative burden, leadership roles, family work conflict, and financial strains become more visible. Later in the career, cumulative fatigue, mentorship burden, and fear of workforce loss can dominate. So, the challenge is not a single event, it's a long arc. In low and middle income countries, surgical systems, burnout can be understood as a predictable output of what I call a stress engine. First, there is a large surgical burden, often with delayed presentation and emergence pressure. Second, there is workforce scarcity, which means more call, more hours, and less recovery time for the available team. Third, there are resource limitations, equipment gaps, theater bottlenecks, and variability of supplies. I know many present here can relate to this. And fourth, there is often a professional support gap, including limited mentorship, limited confidential counseling, and fewer structured wellness programs. Research from Rwanda has shown that equipment shortages, staffing challenges, and poor working conditions are strongly linked to burnout risk. So burnout is not random, it is produced by the system. A systematic review estimates burnout in surgeons and surgical trainees at roughly 47%. That level of distress has consequences at three levels. For clinicians, it brings exhaustion, reduced accomplishment, depression risk, and attrition. For patients, it may contribute to communication failures, reduced attention, and weaker continuity of compassionate care. For the wider system, it leads to absenteeism, turnover, loss of training investment, and even longer waiting lists. A powerful example comes from qualitative work by Eugene and colleagues with perioperative professionals across Rwanda. Participants described a pattern of denying burnout until they reached physical exertion. They spoke about staffing gaps, repeated exposure to bad outcomes, equipment problems, and a strong moral drive to keep serving despite those pressures. That is a real-world portrait of how moral commitment can coexist with wellness risk. So, this study adds an important nuance. Providers describe reduced personal and collective accomplishment, meaning that burnout can become a system's problems even when individuals remain deeply committed. The key lesson from wellness research is that we should not ask individuals only to cope better. We must design systems better. At the individual level, deep sleep protection, setting boundaries, reflection, and early help seeking are important. I encourage everyone to know his or her limit. At the team level, mentorship, peer support, routine debriefs, and better communication matter. At the institutional level, reliable equipment, fair scheduling, protected rest, confidential support services, and career development are essential. And at the system level, we need force expansion, workforce expansion, protected staffing, equipment financing, and wellness policies that are measured and reviewed. WHO guidance supports organizational interventions and manager training, while systematic reviews show that both individual and workplace level intervention can improve well-being. But the most sustainable gains come when root causes are reduced. So the practical response is to acknowledge the risk, measure it locally, fix team and equipment gaps, and build mentorship and support into routine surgical practice. Because wellness cannot depend only on personal toughness. Rwanda's efforts to expand the surgical workforce offer an important opportunity to connect workforce growth with workforce. My take-home message here is simple. Wellness challenges begins early, evolve across surgical career, and intensify where the burden of disease is high and system buffers are weak. Burnout is not an individual weakness. It is often a systems signal. For Rwanda and similar settings, supporting surgeons and surgical teams is part of strengthening access itself. If we want surgeons in every district hospital, we must also build wellness into every surgical pathway. Thank you very much, and I'm happy to take questions.